I wanted to talk a little bit about what's old is new and new is old, where we are with neuromodulation and ablation. Here are my financial disclosures. I'm going to be talking about stimulation. So some of these relate to that topic, though I will maintain equipoise. Plus, many of the concepts I will be talking about are not FDA approved and are often offered in an off-label fashion. So oftentimes when people are referred to the neurosurgeon that treats facial pain, or the neurologist, or anybody that treats facial pain, they come with a diagnosis of trigeminal neuralgia. And it's just not true that the people that are being sent have trigeminal neuralgia all the time. And in fact, probably out of all those people that are sent, depending on the practice, it can be only about 10 or 20% that have true trigeminal neuralgia. So there are other types of neuralgia which are covered in other aspects of the presentation. But one of the things that I'll be talking about is trigeminal neuropathic pain. And this is differentiated by trigeminal neuralgia, both on physical exam and mostly on history. So what's included in that? Well, sometimes this can be painful neuropathies where there's injuries to nerves or post-herpetic neuralgia. Sometimes this can be post-stroke or multiple sclerosis pain. And sometimes this can be the result of some of the interventions that we've had to treat trigeminal neuralgia along the way. So we're all familiar with this table, which looks at classifications of different types of trigeminal neuralgia. And when I'm talking about trigeminal neuropathic pain, the way I defined it is slightly different than this table. We look first as it's defined as trigeminal injury with unintentional injury, oral operations, stroke, central pain, facial trauma, and they separated into intentional injuries, which are trigeminal deafferentation pain. I think for the purposes of this talk, I will call everything trigeminal neuropathic pain, noting that the difference. And this is an important distinction mostly from trigeminal neuralgia because there's two separate types of interventions that are appropriate depending on that differentiator. So both unintentional and intentional trigeminal neuropathic pain respond to stimulation in some of the ablative procedures that we'll be talking about. One type of trigeminal neuralgia, which again, depending on who you listen to, may or may not be called trigeminal neuralgia, is the people that have multiple sclerosis. And this is notoriously difficult to treat and oftentimes unresponsive to typical modalities of treatment for trigeminal neuralgia. So oftentimes I group these into patients that may be candidates for stimulators mostly, and then again, sometimes that ablation. Post-herpetic TN is another thing that does not respond, again, to typical surgeries for trigeminal neuralgia. In central pain, this is that classification, again, of unintentional neuropathic pain, which looks at things like stroke. So when we think about medications, how do these differ? And so when we think about medications for trigeminal neuralgia, you know, the vast majority of people will try carbamazepine or oxcarbazepine. And, you know, this is considered first line. Most of the time, people with trigeminal neuropathic pain will have tried this. It tends to work much less well for those patients than patients with trigeminal neuralgia. And in fact, this can be one way, and not to absolutely distinguish between the two, but to get some inkling that maybe this isn't a typical case of trigeminal neuralgia and belongs in that trigeminal neuropathic pain bucket. When we think about second line therapies, baclofen, lamotrigine, these are things that, again, maybe oftentimes are more common responders to trigeminal neuralgia. And then when we get into this third line of treatment, these are drugs that can treat either or. And so let's talk a little bit about some of those drugs. So in the past, probably about 25 years ago, tricyclic antidepressants were one of the mainstays of chronic pain. In fact, when I was training, these were a mainstay. The problem with this the drug is that it has a lot of side effects that people don't like, and people have to be carefully managed on these, especially in people that are affected by this disorder, who tend to sometimes be older and have cardiac disease. So while these work, these are often not the first line. What are more commonly the first line right now are SSRIs or SNRIs. So these are antidepressants. They work for both pain and depression. One of the interesting differences is when you use these to treat depression, they take about 3 to 4 weeks to work. And when you use these to treat pain, you can see a response as soon as 5 days. And if you don't see that response, you can start titrating up a little bit faster than you would, in fact, for depression. Duloxetine is one of the drugs that can be used. I'm going to flip back to the last slide, because on here, another great drug is an anti-epileptic, topiramate. And, so this can be something that is used often in patients for trigeminal neuropathic pain, or frankly, any type of neuropathic pain. This can make you feel a little bit foggy. So some people really don't like it. It can help you lose weight. So some people really like that aspect. Gabapentin and pregabalin, great drugs, and often the starting drugs for trigeminal neuropathic pain, especially if somebody is not in an acute exacerbation. These are the mainstay of neuropathic agents. They do have problems. Usually we start with gabapentin. One thing I'd like to say is people often get confused because they hear pain med and they think, oh, I'm only going to take this when I'm in pain. And in order for any of these drugs to work, they have to be taken as scheduled. So not just when you're in pain, not PRN, not as needed, but in that regimented way, because this helps things get to a steady state, and it helps for people to really be balanced at the level they're supposed to be at. So gabapentin or pregabalin both take about 4 weeks to work, and that's assuming that you've started the right dose. So making sure that you're taking the medication as prescribed, regimented, at the appropriate dose is essential for all of these medications before saying, oh, that didn't work for me. Or, oh, I couldn't tolerate the side effects. Give it more than a day. Sometimes other things can be going on as well. And so you want to make sure that you've given everything kind of the college try, because having any invasive procedure is not going to be a quick fix, and it's not going to take away all the issues, and it poses some risks. And I know, in this society, we have so many things to do. We want to be done. And, unfortunately, when we're talking about, in particular, trigeminal neuropathic pain, that is not going to be what happens. It's going to take time, no matter what therapy you're using. So, one of the things that's come out a little bit of the headache world is this use of external stimulators. So, I think many of you are really well educated and in terms of facial pain and in terms of different treatments. And, transcranial magnetic stimulation has gotten a lot of attention, because it's great, because it's not invasive, and it's something you can, use sporadically. Having said that, there's some issues with insurance companies. Not many places have a device, but that doesn't mean anything external doesn't work. It just means that we're not so great at delivering it yet. And so in the headache world, what's come out actually and become more commonly used is some external stimulators. These are not at this point FDA approved for trigeminal neuropathic pain, but if they're available, this is something to consider. This is great in terms of having something to do when, you're suffering at home. Part of the issue with any trigeminal pain is it hurts so badly that you feel a lack of empowerment. You don't want to go through that again. You have the PTSD of the last time you've gone through this, and you don't want to have to like wait in the endless phone tree to get to your doctor and then get into the office and then wait for the meds to work. So having some tools at home when you can either keep something at bay or help with an acute event is absolutely imperative. And this may not be a bad place to start for many people. People have actually even just looked at simple TENS units, that right now you can get either when you go for an evaluation for craniosacral manipulation. For the more adventurous, get one and make an appointment with some sort of physical therapist in terms of how it works. Physical therapy use these all the time. And, you can even have a home unit. This can be covered by insurance, or it can be, purchased on Amazon. Though you can do damage with anything you do. If you're careful about how you administer this and it's external, it's hard to do something really damaging. But again, read the instructions, do this under the care of your doctor or your physical therapist. So now what we're really here to talk about is some of these surgical managements of trigeminal neuropathic pain. And I wanted to break this down into neuromodulation as well as ablation. So neuromodulation is where we'll start. And I went from least invasive to most invasive, peripheral nerve stimulation. So this is something where you're just under the skin, and it really has limited a limited risk profile in terms of the device and causing any harm. There's problems with these devices, and sometimes they don't work, sometimes they migrate, sometimes they get infected. But this is, again, is right under the skin, so nothing involving any of the neural structures. Then there's spinal cord stimulation. This is epidural. So, think about a woman having a baby, and, the pain meds go in the epidural space. So that's not in the spinal cord, but outside that area. And so this stimulator goes in a similar space. When we're treating facial pain, it goes up high in the cervical spine. Motor cortex stimulation, which we'll talk about. Now, this requires you having a brain surgery operation where part of the skull is removed and then replaced, and a stimulator is put on that area of motor cortex. And then deep brain stimulation, which is unfortunately named because, I think it has this feeling of invasiveness. Obviously, it's the deep brain. But having said that, out of all the procedures I do, the lowest overall risk profile that I see is with people that undergo deep brain stimulation for a number of reasons, if it's done at a site that does a lot of these. So let's start with talking about those, and then we'll get into some of the ablative things, which are rarely used, but just something I want to educate you about in terms of options. Probably about 30 years ago, we mostly, because of limitations in technology, had ablation tools, which mean destroying some area. Then the pendulum swung when we started doing spinal cord stimulation in the 80s, but progressively more mainstream into the late 90s into the early 2000s to stimulating everything. And, now if you're somebody that follows the neuromodulation literature, what we see is a gradual reversal. Not everything has to be stimulated, and certainly not everything has to be ablated. We're closer still to that stimulation paradigm, but people are starting to think about ablation more and more in indicated cases. So how does neuromodulation work? So, I have this, I have a variety of anecdotes to describe this, but, I think that one of the things and the goal of any of these therapies is to relieve pain to at least some degree. And when we're talking about neuromodulation, you should aim for about 50% improvement. This is especially true when we're talking about trigeminal neuropathic pain. We have some better results in some other disease processes, but I would still aim for 50% there. And so, you know, the way we think about pain is, you know, pain is a normal response that's physiologic, that protects us. So if you go and you touch a stove and your fingers get burnt, you pull your hand away and you think to yourself, gosh, I'm not going to do that again. Well, when you have trigeminal neuropathic pain, you have chronic pain. So while you have that acute pain response, which is helpful, this chronic pain response is a disrupted response, which is not helpful. So rather than just avoiding the stove touching you, you can be anywhere. And, you know, you can get burnt by that stove. So it's almost like you have no control of when this is going to happen. And that can cause a variety of things. People don't want to do anything. The pain can become all encompassing. And so what do? Well, the job of any of these medications, and when I talk about neuromodulation, whether it's a device or even some of the medications, which are neuromodulatory, is they try to treat that abnormal event where, you know, the stove is literally can get you wherever you are, whatever you're doing, and minimize that happening. So the amount of times a day that happens, or how strong the pain is that is delivered by that event. And the goal of reducing that to 50% is that you can have more semblance of a normal life. There are cases, you know, where people have more than that, but this should be the goal. And, you know, I think the biggest failures I see in this therapy are when people have unrealistic expectations that they're going to be the one person that this is a cure for, or maybe at work, because we try it before you have it permanently implanted, but I don't have any other options and I'm going to do this. Before you have this procedure, you will do a trial and you should say, this absolutely worked for me and this was absolutely beneficial. And those are the patients that I see have the best response. So let's talk a little bit more about that. So am I a good candidate for neuromodulation? And I actually changed the term here. Am I a good candidate for surgery? And anytime we're doing any surgery for pain, you know, I think it's important to think about these things. So a diagnosis of neuropathic pain, refractory to medical management, and this says 6 to 12 months. There are times when we'll do things sooner than that. You know, if there's a component of complex regional pain syndrome, you know, we want to treat people sooner rather than later. But this is a good window. And, you know, I think there's, it's often important. I see people sometimes that have had one procedure, haven't gotten the effect they want, and keep having procedures. And sometimes, yeah, I know it's excruciating. I know you have the issue with, you know, just feeling powerless and this pain coming back. But sometimes pausing for a minute and giving something an opportunity to work and getting a chance for the nerve to cool down is the best thing you can do. Again, we want to make sure that we're doing the proper job working you up and that the pain isn't due to something else. There's a lot of mimickers. So you want to make sure that you're getting an MRI and there's nothing else that we're looking at. When we think about medication overuse, you know, one of the things that everybody talks about is opioid overuse. And, you know, so obviously there's problems with addiction with opioids, but also one of the issues is that opioids are good for just a rare subset of people that have trigeminal neuropathic pain. So, you know, you may or may not be that person, but if you get to doses that are super high and outside the CDC guidelines, this can be a reflection, in fact, of, you know, having more pain, hyperalgesia. You can actually have more pain because of the dose of medications you're on. And, you know, then we talk about opioids, but there's a lot of other medications that have a lot of other side effects that can make you actually feel worse than if you weren't on them. Tylenol is a simple example. You can have Tylenol rebound headaches, acetaminophen rebound headaches. And, you know, some of these medications can make you foggy and then not have you have the wherewithal to say, okay, you know, pain is this tridimensional experience. I have to not only get relief from the sensory component, but I have to be with it so that I can coach myself to get through this. you have to try this. And I think that is the best thing. I'm a strong believer in trial. And again, be reasonable about what you're expecting. Oftentimes you'll hear other physicians say, oh, those things don't work. And, you know, why are they saying that? Well, one, the technology has changed and we've gotten a lot better at treating this. But two, nobody has coached the patient or the physician to know that we're not going for absolute pain relief here. We're trying to get 50% improvement. So if you get that, that's a win. And you know, that's, and that may not be a win for you. So I have patients that, you know, come into the office and they say, doc, if you could give me 10% relief, I'd feel so much better. And I have other people where I say, it's going to be 50%. And they say, that's not good enough. And so I think it's really important to think about whether that will make a meaningful difference in the things you want to do. So who are poor candidates? A lot of times people have anxiety and depression that goes along with chronic pain. I would, you know, this fact that you aren't in control and that you're limiting what you're able to do makes these things go hand in hand. What we want to make sure is that you are treated to the best that you can be in this situation with chronic pain for your anxiety and your depression, so that we are giving you the best chance to move forward. I think with neuromodulatory devices, it's arrogant of a physician to think that they can implant a device and make everything all better. Chronic pain takes years to develop. You know, though I showed the 6 to 12 month slide, many people that are suffering for 5, 6, 10 years before they come see me. And a lot has changed in a lot of their adaptive processes in their brain. And so there's many ways we have to tackle that. Alcohol and drug addiction. In fact, if I have people that have alcohol or drug addiction, I do not say, no, you can't have this therapy. I say not yet. And so this is true with anxiety and depression too. I make sure that they're on the road to recovery, that they have 30 days sober and have a pathway to remain sober, or that their anxiety and depression is actively being worked on. Require medical clearance. You know, we're getting more with the improvements in healthcare. There are a lot of people that wouldn't have been candidates for these procedures before that now are candidates. So preoperatively, it's important to go to an expert, somebody that does a lot of these or sees a lot of these. You know, there aren't, because all of these are FDA, are not on label in part, and because insurance does not cover a lot of these, there aren't people that do a whole ton of these. So, you know, it's not like you are going to somebody that does 500 of these a year. But if somebody does 10 of these a year and has been doing this a while, you know, they have a pretty good practice in that regard. Make sure your medications are optimized, as we talked about. Make sure you get that CT or MRI for planning, as we talked about. And one of the things we do is all our patients that have pain, whether they're undergoing a stimulator, an intrathecal pump, or any pain procedure, is, again, we have them work with our pain psychologist. I want to know that whether somebody has, you know, how has this pain affected their life? In chronic pain can ruin your life. And now, do you have the coping skills and the support system to get better? And if you don't, how can we make sure we optimize that before we do this operation to give you the best chance of doing well? So this, again, I really want to emphasize that this is an important part of the treatment of pain. And there are so many people that hear the psychology word and think, oh, the doctor's saying it's in my head. No, nobody thinks it's in your head. We think that pain can ruin your life. And we want to make sure that we are setting you up for success by looking at things that you can objectively do to improve the way you deal with pain. So let's start with peripheral nerve stimulation. Again, the least invasive of these, and you know, similar to TN, 3 distributions: the V1, V2, and V3, ophthalmic, maxillary, and mandibular nerve, these devices do best when somebody either has pain in those typical distributions, similar to TN, you know, where it starts here and then radiates out in that right distribution, or they can even work if somebody has like a pinpoint area of pain, because then we can stimulate right at that area. In order to test these, we still make sure that we can cause tingling in that area that we're supposed to be treating. What I'll do is I'll spend time with people to make sure that I am marking out where all their painful areas are prior to going into surgery, so that I can get my leads covering that area. Sometimes we can't put leads in all different areas. The battery doesn't allow for it. I'm worried that they're going to migrate. So, where is your pain the worst? And this is another important thing that happens when you come to the doctor. We say, where's your pain? And you say, oh my gosh, it's everywhere. And I get it. It might start in V2, but by the time that you have a huge exacerbation, it can be in your whole face and the back of the head. Often think about where your pain starts, and that can help your doctor troubleshoot as to what he or she should be doing and how to treat this. So there's a variety of nerves in addition to the trigeminal nerve that can be treated. These are some branches. And I will tell you that in general, with the technology we have currently, we do best in those that are either in the V2 or V3 distribution. And the reason is the technology is too big for the space that we're working in. So sometimes when we try to do V1 stimulators, they can poke out and cause skin erosion at a higher rate. So here are some images from patients that have undergone this procedure. And so this is somebody that has kind of on the left-hand side, typical V2 and V3 pain. I want to point out on both of these images, when I'm trying to get to V2 and V3, one of the things that I've taken to doing is putting the lead a little bit higher up on the face, almost where the TMG joint is. And, I think oftentimes people can have comorbid TMJ disease, temporomandibular joint disease. And by putting this up a little bit higher, I'm sometimes able to get V2 and V3. This is personal experience and personal preference, but it tends to do the trick. And the problem is if I go out much higher in the jaw, you tend to have higher migration rates as somebody is chewing. So keeping that a little bit higher up has been advantageous. This patient had a variety of things. So those of you that are familiar at looking at these, may see leads in a variety of spots. So we have this over V1, but there was also pain where that craniotomy site was. So there's a lead there. And, this tells a story. So this is a craniotomy site, and that in fact is an older motor cortex stimulator. So that's one thing about different types of peripheral nerve stimulators. Again, the least invasive, and I tend to think these work best. So I alluded to the fact that sometimes you can't put these in different areas, and why is that? Well, they're not the right shape. So here's a lead where this migrated all the way back to the battery, which we generally put in the chest. And, when I first started doing these, my leads moved everywhere. I think the leads have gotten softer. I've definitely gotten better. You might see a number of incisions. They're small incisions, and we try to make them like behind the hairline and cosmetically agreeable places, but we put different loops and strain relief to try to get things like this, or keep things like this from happening. And over time and with experience, people tend to come up with their own tricks to limit this from happening. There's also excitingly new devices. So in contrast to this large battery, you see that looks like a pacemaker and is probably about the size of lemon, not the thickness, but the size. Here's this new battery that is a new device that's come on the market, and things are getting miniaturized. So I'm hopeful that what we offer people for peripheral nerve stimulation will markedly change over the next 5 years. The other thing that we're doing is I alluded to the fact that we have to get that tingling sensation in the area that's treating pain. Well, we do that just to make sure our lead's in the right spot. But now there's newer waveforms where you don't have to feel that tingling sensation, and you can get pain relief without the tingle. And that can be highly appealing, because imagine if your jaw is tingling and you're trying to sleep or you're trying to eat, that can be disruptive. And so having this non-tingling sensation can be beneficial for some people. Some people like the tingling. It's, it's comforting. It's massage-like. It tells them that the therapy is getting delivered. So, I think it can go either way. And some people like one at one time and one at the other time. So, the field is moving forward. One of the things that was popular a little bit of time ago was this idea of trigeminal ganglion stimulation. And so what happens here is very similar to any of the rhizotomy, RF, balloon procedures, glycerol procedures, is you go in through the cheek and you can actually put a lead there. And, the problem with this is that people, they moved out, they fell out. And so now there's been new anchoring techniques and other things to describe that may make this beneficial. And that's neat, because it can get all three areas at once. And that's especially neat for the V1 distribution type pain. So what about spinal cord stimulation? This can sometimes be used, and I wanted to mention it. Unfortunately, it's hit or miss, and a trial is really important in these cases. When you talk about the cervical spine, that's like the pathway from the brain to the whole body. And in the cervical spine is also the nucleus to the trigeminal nerve. And so what we are able to do here is sometimes stimulate the whole body. Sometimes we're only able to stimulate, this area of the neck. And unfortunately, at this point, there's no way to tell which kind of response you're going to have. So this can work well for people, but it can not work at all for other people. It may be worth considering. If you have this in addition to other types of neuropathic pain, this may be something that insurance will cover. And, this person had left-sided pain. And so here you see we put the spinal cord stimulator way up top, and we're able to capture this. And we augmented that with another lead in that distribution. One of the things that can happen is these percutaneous leads can move their cylinder. They look like a pen. And so when they disperse energy, it goes out in all directions, like the sun, in different directions. And so sometimes this isn't the smartest delivery of energy. Sometimes they move. And so you may find yourself in this situation where you need a paddle type electrode. The problem with the paddle electrode is it's much more invasive. And there's actually a lot of muscles in the back of the neck that can make this quite painful to do. So if you opt for a paddle stimulator, please make sure that you've gotten really good benefit for that perc stimulation, and that you're willing to undergo the risks and the pain associated with this procedure to move forward. It would have to be really good stimulation for me to consider doing this. So, we delineate these areas. Most of the time I do these surgeries asleep. There's small incisions, multiple incisions for peripheral nerve stimulators and percutaneous leads, bigger incision for paddle placements. Oftentimes there's two trials. First you try it for 7 days. We have everything external. And, then if that works for you and you say 100%, this is what I want to do, we go through with the permanent case. Where the generator is placed, I do want to pause, for a minute and talk about this. It's really important that you talk to your surgeon about where those options are. So for a lot of reasons, in these cases, it's the chest, but sometimes it'll be the back. Sometimes it'll be low down. If you get your standard dental floss from, whatever grocery store you go to, and you tape it outside your body to different areas, you can get a feel of what that would be like and give your surgeon some guidance on where he or she can put this generator that it'll be least bothersome to you. But again, ask him or her what your options are, because for different reasons, different people have different options. And again, there's a hard part here in terms of programming. This isn't one and done. This is very much like a medication where you have to titrate this to the right level. So what are other kinds of stimulation? I just want to touch upon motor cortex stimulation and deep brain stimulation. This is another example of somebody that underwent motor cortex stimulation. It's interesting that it's actually the motor cortex as opposed to the sensory cortex where you can get benefit. I often will not do this procedure unless peripheral nerve stimulation has failed. The only time where I may consider this as a first line option is when somebody has a stroke and there's something in the brain that is altered, and I can see that on MRI, then it's less likely for a peripheral nerve stimulator to work because the problem isn't lower down, it's higher up. And so I want to go one level higher and try to control that pain. And so for this procedure, it's a little bit more involved. It's a craniotomy. It's taking off part of the skull and doing monitoring as well as an MRI to know exactly where your face is on this. And oftentimes you'll stay in the hospital a day or two. These have to be programmed by somebody that really knows what they're doing. And, you know, this is often like the hardest part of both this and deep brain stimulation, finding somebody with enough experience to do the programming in a way to give you a chance for success. And so oftentimes before the surgeon even considers this, a conversation should be had about who's going to do the programming. It's not just the company representative like it is for other devices. This has to take somebody that has experience in this area. When we talk about deep brain stimulation, there's a number of ways and things we can target. Here's an example of somebody with a stereotactic frame on getting into that precise localization deeper in the brain, where we're looking at the exact right spot that works for you and your pain. Oftentimes, because multiple pain pathways may be involved, you see here on the right lower corner that I actually have 2 leads implanted there to try to stimulate both areas of the brain. And when we're talking about deep brain stimulation, that can even be trickier than motor cortex stimulation. I think the easier part is that we use similar settings that we do for other aspects of deep brain stimulation programming. So the doctor has some more familiarity. The hard part is the brain is harder to trick in that area. So we often have to shuffle between different programming settings, and exactly what will be individualized for you can be a challenge. So, you know, I think when we think about the title of this talk, you know, I've talked and spent the vast majority talking about stimulation and things to do before stimulation, but there are options that involve ablation. Trigeminal tractotomy is something that is very rarely done, but something that I want to talk about. As we mentioned when we were stimulating the cervical spine, that trigeminal nucleus, it goes in that location. So, you know, you can actually ablate that nucleus in order to relieve some pain. This is an operation that has significant risks because this is an area of the brain where, you know, it's pricey real estate. A lot of things go through that area. So this is not a first line treatment. This is probably almost a last line treatment, but it's something to be aware of in the right situations. And when we're talking about ablating, there's a variety of things we can use. What people had traditionally used in the 60s and 70s was a radio frequency type ablation device. You know, there's been some work with laser and microwave. Right now, what you'll hear a lot about is focused ultrasound. And most of these are external ultrasound devices, though there is some work being done on devices that are placed similarly to how those are radio frequency probes were, with the advantage being it can get to different locations and it can be better controlled. So again, similar to that picture that I showed you for deep brain stimulation, we put on that frame and get us in the exact right area that we're targeting. And, you know, one of the areas in the brain that we can target, we showed that we could target the trigeminal nucleus and the spinal cord, but we can also target the brain. And, you know, this is called a cingulotomy. And so this is for people that are in truly intractable pain. Oftentimes this is done on patients with cancer, though it is done on people without cancer. And what this is actually making a lesion, oftentimes on both sides of the brain, in the area that controls your response to pain. It's really interesting because people, people have a cingulotomy, you'll ask them if they're in pain and they'll say yes, but it doesn't bother them. So it's a really interesting thing. And even more interesting, opioids can be weaned really quickly. So it's just this truly a way to disconnect the response that correlates with the sensory symptoms. And this is actually something that is pretty tried and true and has been around for some period of time. There's multiple ways to perform this. And then more recently, people have started looking at deeper structures similar to those areas of the brain that you would target with deep brain stimulation now that we have focused ultrasound. And so this is work that's been done in Italy and hasn't hit mainstream in the US yet, but there's ways of creating an ablation in that area where you would stimulate with the deep brain stimulator that have been shown to have promise in people that have really intractable pain. So again, similar to peripheral nerve stimulators and other types of stimulators where there's things coming down the pike. Also in ablation, I expect to see more and more technologies to help treat pain. So in conclusion, I think the hardest part here is making sure that you have the right diagnosis. People with trigeminal neuralgia don't respond to therapy for people with trigeminal neuropathic pain do, and vice versa. History and clinical exam are essential. Multiple neuromodulation options are available and our ablation options. And make sure you find the right provider and the right providing team before you move forward with this.